Greetings and welcome. My name is Brad Monk, and on behalf of Creative Educational Concepts, I would like to welcome you today to this educational activity entitled Advancing Cervical Cancer Care, Navigating New Therapies, Guidelines, and Patient-Centric Approaches. Today's program is brought to you by Creative Educational Concepts. They're award-winning, they're accredited, and they participate in continuing medical education for clinicians worldwide. Now, we may include discussions of products or devices that are not currently labeled for use by the US FDA. We'll try to point that out to you. Again, my name is Brad Monk. I'm here in West Palm Beach, Florida, as part of Florida Cancer Specialists and Research Institute, where I'm the medical director of late-phase clinical research. I'm also the vice president and founder and director of GOG Partners. We're going to talk about several of our studies. And I'm joined by my good friend, Kimberly Halla. Kimberly, introduce yourself. Tell us what your practice, where you practice, and what your practice is like.
Thanks, Dr. Monk. I'm very honored to be here with you today as well. Again, my name is Kimberly Halla. I'm a family nurse practitioner, currently working for Arizona Center for Cancer Care here in Scottsdale, Arizona. I'm lucky enough to be a part of a great research facility as well, really focusing on gynecologic cancers and really meeting the needs of our patients who come into us. And I'm excited to be here with you today. Thank you.
Well, we're excited to have you. I know you look very, very young, but tell us how many years you've been a nurse practitioner.
You're very kind, very kind. I've been a nurse practitioner since about 2015. But prior to that, I was an oncology nurse. I worked hand in hand with you at the bedside as your nurse as well. And many years of experience as the bedside nurse, as well as answering that triage phone and really working with our patients to be able to get them through therapies and medications.
Well, it's good seeing you. I've transitioned on, obviously, from Phoenix to here in Florida, and it's good to reconnect with you. I'm interested to hear what you're doing these days and what your experiences have been with treating cervical cancer. Our learning objectives today are to evaluate the evolving treatment landscape for newly diagnosed advanced and recurrent cervical cancer. We're going to discuss chemotherapy, radiation, immunotherapy, and importantly, what's new, antibody drug conjugates, and even highlight some ongoing clinical trials that we're excited about. Our goal today is to develop individualized treatment plans, as well as personalized treatment plans. So those are different. When we individualize a treatment, it's best for the person, but when we personalize it, it's bad for the tumor. Okay. It's a tumor-directed, molecular-based intervention. So we're going to consider both of these, both clinical as well as targeted approaches. It takes a team, and that's why we're very happy to have you here today, Kimberly. So, COVID was terrible. But if I learned anything from COVID, I learned two things. Number one, if you don't get vaccinated, you might die. And unfortunately, many of us lost friends and colleagues and even family members. Well, that's relevant to cervical cancer. Like COVID, cervical cancer is caused by a virus, the human papillomavirus, for which there is a vaccine. It's almost 100% effective. It's even more effective than the COVID vaccine, and it's safer. It's not an mRNA-based vaccine like the COVID vaccine. It's a protein. Yeah, that's it. It's a protein. And basically the side effect is it hurts because it's a needle in the arm. The serious adverse event is skull fracture, because if you get it in the arm, you may fall. So we invite you to have your individual sit there, make sure they're not having a syncopal episode. The indication is to begin at 9 years old before sexual debut, boys and girls. It's approved all the way up to age 46, and it prevents vulvar, anal, vaginal, cervical, and head and neck cancer. Wow. Why wouldn't you get that? Okay, because you don't know. So the purpose of today's opportunity is to educate you about the efficacy and safety and the global indication for HPV vaccination. Now, it started with 4 HPV types, 6 and 11, which are work-causing types. 16 and 18, which are cancer-causing types, and now we added 5 additional cancer-causing types. And so, Kimberly, obviously you're aware of this, and do you talk to women with cervical cancer or even non-cervical cancer patients about HPV vaccination, and how do you discuss that with them?
Yes, we talk to all of our women in regards to HPV and vaccines. It's a great learning opportunity, right? It might not be able to be effective at that point when they are diagnosed with cervical cancer. However, what about their children? What is a great learning opportunity for their children, their grandchildren, their nieces? It's a great point and a touch point where I can have that discussion with our patients.
Yeah, it's not just about cancer treatments, about cancer prevention. So good for you. And the reason you said women, because that's all we see. But if we saw men, obviously we would talk to men about it. Listen, it works so well that it started with 3 immunizations, but if it's given when a person is young, it's only 2. We used to think, oh, maybe it's not going to last. We defeated that when it's given in the younger sort of 9 to 12 age group. The immune system is so susceptible, the immunization actually lasts longer. It's actually more immunogenic than if we delay it. So it's great. So I told you we learned 2 things from COVID. Number 1, if you don't get vaccinated, you may die, and that's relevant to cervical cancer. Second thing we learned from COVID is that if you want to know if you have it, you do a viral test. And most of us, many of us, me, have had a COVID test. Okay. Well, again, relevant to cervical cancer. If you want to know if a patient is at risk, a woman is at risk for cervical cancer, you do a viral test. And again, we don't pap smear anymore. We pap test, but you can still do a pap. But in that cytology liquid, you can assay the virus. More than 30 types. It's easy. And we know that 16 and 18 are more dangerous. So the consensus is, let's do a viral test, an HPV viral test for cervical cancer screening. If you want to look at the cells under the microscope, that's fine. It's sort of hard to throw the vial away. So many of us do repeat testing. And if you are virally negative and cytologically negative, the patient that is, she's good for 5 years. She's, well, maybe she's going to get cancer in 5. No, she's not. And remember, we can overtreat precancerous lesions. So because we can overtreat precancerous lesions, cause fertility, infertility, early pregnancy loss, we don't start screening until the age of 25. So that's a great message. And I'm very passionate about it. As a medical school, I worked in the lab where the HPV vaccination was being developed at the NIH. And that's one of the many reasons why I became a cervical cancer researcher. So it's also an illness of marginalized populations. We're very passionate about inclusivity, getting the vaccine to everyone, testing for everyone, and we would be remiss if we missed that. Now let's talk about invasive disease. Invasive disease starts in the epithelium of the cervix. Precancerous lesions are called cervical intraepithelial neoplasia. Sort of bifurcation in the nomenclature: low grade and high grade. Low grade are more viral infections and could resolve. High grade lesions need to be treated either with excision or ablation. We also changed the staging system from 2014 to 2018. The 2018 staging system now involves the lymph nodes. Okay. So when we talk about cervical cancer staging, we need to refer to either the 2014 staging system, which was clinical, or the 2018 staging system, which includes radiology. And obviously that's what we prefer as the most recent staging system. And it's the FIGO. I'm going to say it in English, but it's not Federal International Gynecologic Oncology Staging, FIGO. Obviously, when caught early, cervical cancer can be removed surgically. And if it's a small lesion, we used to do a radical excision called a radical hysterectomy. Now, based on the SHAPE trial, we can do a simple hysterectomy published in the New England Journal. If it's greater than 2 centimeters, you still need a radical operation, which includes the paracervical soft tissue, the upper vagina. If the tumor is deeper than 3 millimeters or has lymph vascular invasion, we also have lymph nodes that can be removed, and we can actually inject dye into the cervix and biopsy that using sentinel lymph node biopsies, which prevent lymphedema. Now, if you can't cut it out, basically, if the cancer is greater than 4 centimeters, you should give chemotherapy and radiation. Kimberly, do you have radiation in your practice, or do you refer it out?
No, we have radiation in our practice, and it's a great tool and great to have them right here in our building to have that continuity of care that our patients are able to go back and forth. Because you well know with radiation, it's daily along with that weekly chemotherapy. So it's great to have it really close for our patients.
Tell us about that weekly chemotherapy.
So weekly chemotherapy with those cervical cancer patients are cisplatin or carboplatin if they're cisplatin intolerant. And it's a weekly low dose chemotherapy that's really radiosensitizing that tumor in order to make the radiation more effective for our patients. So it's once a week for about 6 weeks during their radiation. So radiation lasts about 5 or 6 weeks, and that's not including the brachytherapy. But those patients have that available to them here.
So the radiation Monday through Friday for about 5 weeks is external. Tell us what brachytherapy is.
So brachytherapy is internal radiation pinpointed to the vaginal cuff or that top of the vagina, or sometimes reoccurrence is more occurring there, right? So we want to make sure we get pinpoint accuracy to where we're able to identify those areas of the vaginal cuff. Absolutely.
Yeah, that's interesting. And it's important because the radiation can be put right inside the cervix, and we do image guided brachytherapy. In other words, we image the cancer and we tailor the brachytherapy to where the cancer is. And we do intensity modulated radiotherapy, IMRT, which spares, for the most part, the bladder and the rectum. So it's a very tailored, highly specialized, and I know your radiation doctors there in Scottsdale personally. They're elite, and they do high quality external beam, intensity modulated radiotherapy, and then they do brachytherapy in the cervix, and they use imaging to guide it. So that's great. Really, the biggest achievement in treating locally advanced cervical cancer, that is, cancers that cannot be resected, is a study that was done collaboratively with the GOG, which both of us are privileged to be a part of, GOG 3047, and also the European network, which was called NGOT CX11. The sponsor called it Keynote 18. So all three of those names mean the same thing. And it basically took unresectable cervical cancer, what we call locally advanced cervical cancer, randomized them to the standard treatment that Kimberly just described, external beam and internal brachytherapy, radiation with chemotherapy, placebo, the standard, or adding pembrolizumab to the treatment phase and in maintenance. Interesting, right? Because being virally related, cervical cancer is and should be very, very immunotherapy sensitive. And we did it. And we published it. And it got FDA approved in January 2024. Okay, so now this is sort of the newest and greatest, adding immune therapy to chemotherapy and radiation in cervical cancer. Now, the indication is complicated because the FDA didn't approve the indication to all the sorts of patients that were enrolled. The FDA said, look, and they used the 2014 staging system. So I'm just going to say what it is. The bladder, rectal, sidewall, hydronephrosis involvement, the highest risk patients, that was the only patients that were indicated to receive chemotherapy, radiation, and pembrolizumab. And the NCCN was sort of taken back that it didn't include all the patients that were enrolled in the study, which is what you would think the FDA would do. They agreed with the design. We did it. We met the primary endpoint, and the FDA said, we're only going to give you the indication for the highest risk patients. Well, since then, we've had an interim analysis too. It's looking better, which is what happens with immune therapy. And on February 10th, 2025, the NCCN recommendations were updated, and it's just clearer now. Yes, chemotherapy, pembrolizumab, and radiation preferred for those patients that have rectal invasion, bladder invasion, attached to the pelvic sidewall or hydronephrosis, preferred level 1. And if it's node positive only, then it's a level 2B. So it's still NCCN recommended, just not the same level of the recommendation. So again, I keep coming back to my expert here. Kimberly, have you begun to use pembrolizumab with chemotherapy and radiation? It's a relatively new indication. Cervical cancer, fortunately, is rare. Fortunately, most patients are caught early and treated surgically. But I know you guys do treat cervical cancer patients with chemotherapy and radiation when it's not possible to resect it.
Absolutely, we have. We're excited with the new indication in February because, like you said, going back and forth between 2014 indications and 2018 indications, it was difficulty getting insurance approval. We are so glad it's there now, and we have started with the use of pembrolizumab with our chemotherapy and radiation patients, and are excited for them for the opportunity. Again, like you said, many patients weren't given the opportunity. Now we have all of our patients given the opportunity, as HPV should be, treated with immune therapy. They're going to do very, very well.
Interesting. And there was this concern because pembrolizumab can cause diarrhea, colitis, if you will, and radiation and chemotherapy causes diarrhea, that they might sort of cause an unacceptable combination of GI effects. What's been your experience with the side effect profile of pembrolizumab when given with chemotherapy and radiation in locally advanced?
This is my pearl. This is my go-to thing. Let's intervene quickly, right? Give your patients permission to call you, right? If you can intervene at grade 1 and grade 2 toxicities when they don't get to a grade 3 toxicity, that is your sweet spot. Giving patients permission to call you. Let's intervene. Let's fix these issues. But that requires that multiple disciplinary approach, right? You have to notify your triage staff. You have to notify your radiation staff. You have to notify the nurse answering the phone in the chemotherapy room. It takes a lot of people to get these patients through treatment.
Yeah, it's interesting. And I've learned this as I've treated several patients with immune therapy, not just with cervical cancer, but if it's sort of unclear whether the diarrhea, let's just say, is related to a medication like lenvatinib, which I can stop and it should get better tomorrow. But here I can't do that. One of the go-to tests is a CAT scan. I used to say, well, let's do a colonoscopy. The GI doctors are hesitant to do that. The findings on a CT scan are generally pathognomonic for colitis. Okay, it caused bowel wall thickening. And it's not always specific, but it's very sensitive because the colitis could be to a C. diff, infection or something. But if you don't see a picture radiologically of colitis, it isn't that. So, and the beauty of it is most ER doctors, or not ER doctors, most ERs have a CT scan right in the emergency room. So it's a pretty simple test. And to your point, if it is colitis, which still does happen, then that's treated with immunosuppression, and you phone a friend and get your GI doctors involved with that. I'm excited that you're on the cutting edge. Is one of your reasons for the enthusiasm because it probably increases the cure rate? Is that the idea?
It absolutely does. Not only does it increase that cure rate, we can continue to treat with the pembrolizumab, right, in that maintenance kind of setting, and give them that opportunity to be able to do that. Whereas before, we didn't have the maintenance portion of this for our patients.
Yeah, that's very cool. So if a patient is immune therapy naive, which most of the patients still are when they recur, or if they recur, when is probably negative. If a patient recurs and is immunotherapy naive, or if they're diagnosed with stage 4 de novo, or if they don't recur, it just never goes away. So stage 4 would be persistent or recurrent. That bucket has traditionally been treated with the chemotherapy, platinum and taxane, Protocol 204 that I had the honor of being the first author in the Journal of Clinical Oncology. We added bevacizumab to that, which was a small incremental benefit. But as you sort of taught us, we could then also add immune therapy. Now there's this idea, well, that's four things, Monk. That's platinum, taxane, bevacizumab, and immune therapy. And you're right, it is. And it dramatically improves. I know that's dramatic, but when something's dramatically, you can be dramatic. It increases the survival more than a year. And in the high CPS, CPS greater than 10, there's a tail, and you might even cure as many as 30% of the patients. Think of that, curing metastatic recurrent cervical cancer. The FDA approval is a PD-L1 score CPS greater than or equal to 1. There's another study called BEAT-CC. BEAT-CC is a very similar study, but required bevacizumab. So in KEYNOTE-826, the study that I just described with pembrolizumab, the bevacizumab was elective because bevacizumab probably shouldn't be used if there's a high risk for a vaginal fistula or a contraindication to bevacizumab. But BEAT-CC eliminated those patients because they wanted bevacizumab to be added to it. And that study has also been published, still not in the NCCN guidelines. So it's really a pembrolizumab world. Both, you and I have a lot of experience with that. What's been your experience with pembrolizumab in the recurrent setting this time with chemotherapy? I'm sure you've treated several patients.
Unfortunately, I get to answer that question is yes. We've treated several patients with that regimen, and it's harder. It's harder on the patients, but given that reoccurrent or that progressive disease, we owe it to them. We owe it to them to give them everything that we have. Right? They're young women. They're in their 40s and 50s having this reoccurrence in their life, and we owe it to them to be able to offer them, immune therapy, chemotherapy, bevacizumab, and make sure that we can handle those toxicities when they do happen. And if they do happen, we intervene rather quickly to be able to keep them on medication safely.
Yeah, I hear all the time, well, my family member had this sort of cancer and got treatment, and he or she died anyways, didn't do any good. That's not the scenario here. This stuff works. Can you think of any dramatic cases where in the recurrent setting where you use chemotherapy and pembro with or without bevacizumab? Can you think of any dramatic cases?
Dramatic cases, gosh, probably not dramatic. I think that every case is dramatic, right? Because it's life altering, right? It's life altering, and these women are, like I said, they're young and they're healthy and they are in the prime of their lives. They're in the prime of their careers. So being able to offer them something that's dramatically going to improve their longevity and their life, everything is dramatic at this point, right? And that's what this regimen is able to offer.
And you're a cheerleader. We have to be optimistic. And I have 3 patients that I think I've cured. I mean, I'd never seen that before. So patient with widely metastatic, biopsy proven pulmonary disease. I think all her cancer's gone. It's been 2 years. She's off pembrolizumab. So, at some point you have to say, look, we're not treating you and the cancer hasn't come back. I don't know what the definition of a cure is, but that's pretty amazing. It's unprecedented. All right, so frontline treatment, chemotherapy and radiation. Ideally, let's prevent it with vaccination. Let's screen for it with viral testing. Let's cut it out if it's detected early, but if it's chemotherapy and radiation, we can add pembrolizumab to it, particularly in the patients with bladder, rectal, sidewall, and ureteral involvement. But even then, there are patients that slip through. There are patients that slip through, some of which are checkpoint naive, some aren't. Most patients have had immune therapy before because we just talked about KEYNOTE-18 and BEAT-CC. What is sort of your go-to treatment and we call it the second line because chemotherapy and radiation is not considered a line of therapy. Someone asked me the other day, why is that? And I said, I don't know, it's probably my fault. But in the second line, after KEYNOTE-826 or BEAT-CC, what's your go-to regimen?
And CCN guideline proven. It already chose me, right? We're going to do, TIVDAC. We can do that. We can have a great enrollment in that, and our patients are doing well. Tell me a little bit about what you go through.
So let's call it tisotumab vedotin. And
Okay, let's do that.
Tisotumab vedotin. You know more about it probably than I do. Tell me what tisotumab vedotin is. You ask me and I answer with a question. How's that? I like to hear you speak more than you like to hear me speak. So go ahead, tell me what it is.
Thank you very much. So tisotumab vedotin, right? It is an antibody drug conjugate, which was new coming into gynecologic settings. It's an antibody drug conjugate targeting tissue factor, right? It is a targeted therapy for our patients who have cervical cancer. Cervical cancer has an expression of tissue factor, and we're going to target that and really take advantage of it. It is an infusion that our patients get in the infusion center. It's about a 30-minute infusion for our patients, but it does have some side effects that were new to our world that we had to educate our nurses and our patients on. And again, using a multidisciplinary approach, we had to involve eye care, right? This is something that we weren't used to in our setting. So we had to involve our friends and our colleagues in ophthalmology and optometry to make sure our patients' eyes were safe during this treatment. We make sure that they get the appropriate steroid eye drops at this point. Make sure we get lubricating eye drops coming from Arizona. I think everybody needs lubricating eye drops wherever we're at. So making sure our patients were going to be safe during this treatment. So we're excited to be a part of, and you and I were a part of this trial when we were here in Arizona together, and just to see the progression of patients being able to, failing standard chemotherapy, but then going into antibody drug conjugates and getting a good response, and sometimes even a complete response on these trials.
Yeah, it was a game changer. And this study, Innova TV, sort of in 204, you're right, we were the leading enroller, I think, in the US to that study. And the response rate by a blinded independent central review by around 100 patients, 24%. Now, the FDA said, oh, that's a lot better than anything we've ever seen. So gave accelerated approval to that. And that was really exciting. And I'm just saying, because we're the leading enroller, we got audited by the FDA, not for cause, but they just wanted to make sure that we weren't making it up because it was so incredible. And we passed the audit, thank goodness, with one of our researcher associates, Terry Thomas, and it got FDA approved. Now that was and that was balancing the adverse events, obviously. So the vedotin linker payload, which is an MMAE antitubulin payload, is well established, and there are several vedotin attached to an antibody like tisotumab. That's the antibody. And so we sort of understand the class effect, the adverse events, you describe them. It can also cause bleeding. I don't like the word hemorrhage because, a nose bleed is not a nose hemorrhage. And you had mentioned some cold packs, what I call cryotherapy. We can induce vasoconstriction by cold pack over the eyes and external nares, and also vasoconstricting eye drops, because it causes conjunctivitis, which is very easy to assess because you look at the conjunctiva, and if it gets in the cornea, it's called keratitis, and you have blurred vision. So I think we figured that out with the initial study. I'm going to talk about the phase 3 in a minute. The label, the US prescribing information, requires that patients see the eye doctor before treatment in every cycle. Are you doing that?
Absolutely, we are. We, the last thing you want is your gynecologic oncologist giving you an eye exam, right? You want the experts to be able to do that. Dr. Monk, when's the last time you've done a slit lamp exam, right? It's been a few days. So you want them to be safe, right? These are life-altering side effects that if not approved or taken care of, you want someone who is an expert taking care of that. So they see them at baseline and then before every infusion. And in fact, it is that important that if they have not seen their eye care professional, they don't get treatment, right? It is that important.
Yeah.
And if they can't give themselves eye drops, this, we need to work on something. We need to come up with a
Right.
plan for them. So it's that important that they do that. Absolutely.
Yeah, it's interesting, and I don't mean to be unprofessional here, but I asked an optometrist the other day. I said, "Do you do slit lamps?" And he looked at me. He says, "Dr. Monk, do you do speculum exams?"
Touche, touche.
And I thought the guy was pretty quick. So that's just sort of the technique that they use to adjust the depth, and looking, from the surface all the way to the retina. Well, that's interesting, and I appreciate your availability and your sort of passion for keeping patients not only alive but well. So that's interesting. So we took that accelerated approval, and the FDA said, "Look, you got to prove it," because it was a single arm study. So we launched a study called Innova TV 301, also a GOG NGOT collaborative study that was published last July in the New England Journal by Ignace Vergote. And it was versus single agent physician's choice chemotherapy. And because that's what we were using, these medications like topotecan, gemcitabine, vinorelbine, and so on. And in a randomized trial, okay, it basically met its primary endpoint, almost 500 patients, and not only improved response rate, which we knew, not only improved progression-free survival, which is what happens when you shrink tumors, but also improved overall survival with a hazard ratio of 0.70. So that was pretty exciting, that it had a 30% reduction in the risk of death. So at any given time, when the patient is on tisotumab vedotin versus physician's choice chemotherapy, single agent, they have a 30% better chance of being alive.
I'll take those odds any day.
I know, right? But it comes with a cost. And you were talking about in Keynote 826, the cost of chemotherapy, pembrolizumab, with or without bevacizumab. It comes with a cost, but I think the benefit justifies the cost. And with wonderful advanced practice providers like you and the pharmacists and other members of the eye professionals, I think we can get through this. So what's been your experience with tisotumab vedotin now that it has flipped from accelerated approval to regular approval? And by the way, in the NCCN guidelines, and that's what you said, I just follow the guidelines, and it's level 1 preferred in this second line. So what's been your experience?
Experience with tisotumab vedotin is been a challenge in the beginning. Again, now that, like you said, we're past the accelerated approval point, but it gives a different opportunity. Now, remember, these women have already failed,
right,
chemotherapy and radiation, and then they failed carboplatin, paclitaxel, bevacizumab, pembrolizumab. They failed the best chemotherapy that we had. And so giving them an option, because prior to this, this trial, what were we going to do? Throw chemotherapy at them again that they've already failed. Right. Now our patients with an option, again, you've already listed out the 30% reduction, right, in how they responded to chemotherapy. So we're doing well. Our patients are learning. We are learning with them. We've learned with them that if you move the eye care or the cryotherapy just over the bridge of the nose, we decrease the nasal bleeding, right? So we're learning as we're going, and we're continuing to learn with our patients.
How do you explain to a patient what an antibody drug conjugate is? That it rolls off your tongue because you say it all the time, but a patient doesn't know what that is. How do you explain that?
Absolutely. I give them that visual, right? So I talk about that 3 linker phase. You have the MMAE, you have the linker, and then you have the payload. And so as I'm telling my patients, what are we giving them? And it's infusing into their body. It's attacking tissue factor. It's going into the cell. It disrupts that bleeding cascade. And it basically causes that tumor to bleed and to die. Mm-hmm. So when we talk about that, it's giving a visual of what that ADC or that antibody drug conjugate is really doing, because it's different than chemotherapy, right? It doesn't attack those rapidly dividing cells that we talk about with chemotherapy. It's really targeted therapy. And that's something our patients are excited about.
Yeah, it's the idea is that it enriches the payload, the chemotherapy in the tumor microenvironment. But it rather than attack the entire body, it attacks the tumor because the tissue factor is overexpressed on the tumor cell. That's the point. That's what you said. So that's interesting. So in addition to tisotumab vedotin, we keep moving. Okay, we keep moving, and we now have a study called Destiny Pan Tumor 02. And this is a study of another antibody drug conjugate, this time against a different target, HER2. It also is a different payload. So if a patient is resistant to tisotumab vedotin, because that's an anti-tubulin payload, the trastuzumab deruxtecan payload is a topoisomerase. So I think that you can use them sequentially. I'm not sure you can use a topoisomerase payload after a topoisomerase payload, although I don't know for sure. And so we're using this in all of our gynecologic cancers. And as you know, this is now FDA approved in pan tumor, meaning every single tumor, including cervical cancer, which is what we're talking about, has an option for trastuzumab deruxtecan if they're HER2 3+ through immunohistochemistry using the gastric scoring, or according to the NCCN, if they're 2+. Now, the challenge here is that of the 3 gynecologic cancers that we treat, endometrial, ovary, and cervical cancer has the lowest expression. But I want you to keep that in mind. I want you to test for HER2. And really what we're getting into now is sequencing, which is very tough. I think if you were to find the rare, a 3+, I might use TDXD before tisotumab vedotin. I think if you were to find a 2+ HER2 IHC, I probably would use TV. There's no real right answer there. So again, to start from the beginning, chemotherapy, radiation, with or without bevacizumab and pembro, particularly for the higher risk groups. If they're IO naive, platinum, taxane, IO, with or without bevacizumab. In the second line, TV, tisotumab vedotin, unless they're HER2 IHC 3+, which is very rare. So the sequencing, I think, is pretty clear. I want to end a little bit talking about combinations. So I think the NCCN has spent a lot of time making the guidelines even easier to understand. They were already easy, but they're even easier now. And in the newest version, again on February 10, 2025, one of the things was that you could give pembrolizumab and TV together. Okay. And that was a study called Innova TV 205, published by Vergote and me and others in the Journal of Clinical Oncology. So why would you do that? Well, you do that because if you were to get to the second line and the patient was IO naive, you don't have to decide. It's not a sequencing issue. It's an opportunity to give both medications together as per the NCCN and as per our study in the Journal of Clinical Oncology. So I think the good news is we have lots of options. I want to finish and talk about the next antibody drug conjugate platform, which is TROP2. So we got tissue factor, okay, we have HER2, and now we have TROP2. And TROP2 is being studied in another a study, obviously done by the GOG and the European team. The TROP2 studies, at least for sacituzumab tirumotecan, which is the same antibody as govitecan, but a different payload, those studies are called TroFuse. And so this is TroFuse 20. That's what the sponsor calls it. TroFuse 20, again, is in the second line, same setting where tisotumab vedotin is being used. And it also, like 301, is versus physician's choice chemotherapy. But here's the kicker. In this trial, which is called GOG 3101, the single agent control arm now includes TV. How cool is that? So you can now go on this second line randomized phase 3 trial, and rather than get which we already did, TV and physician choice single agent ineffective chemotherapy. Now you can get TROP2 antibody drug conjugate, sacituzumab trumatecan, versus physician's choice chemotherapy, which in this country includes tisotumab vedotin. So we keep building brick by brick. We build radiation to chemo, chemotherapy to anti-angiogenic to immune therapy to ADC to a better linker payload, probably topoisomerase, ADC now to the third version. So if you see a patient in the second line, it's open in many places around the country, GOG 3101, Trofuse 020, second line, IO exposed, because that's really the best practice and what we're trying to defeat. We're not trying to treat patients who never got IO. We're trying to teach people to use IO in the front line. Now there's another sacituzumab antibody drug conjugate, sacituzumab govitecan. And that was, obviously that's approved. And we just saw another one that you're probably familiar with, Dato-DXd, that was approved earlier this year in HER2 positive breast cancer. Do you have any experience, Kimberly, with the sacituzumab medications at all in GYN cancer? And if you don't, I'm going to ask your help.
You know what? We don't, but I would love to. I am always encouraged by the women who enroll in clinical trials, and I am humbled by them every day. So I am excited to offer them this opportunity. So let's do it. So
you can purchase sacituzumab govitecan. The study that I just described as sacituzumab trumatecan. I ran into a guy on Saturday, at a meeting. He says, "Remember me?" And I've already taught you what the answer to that is. No. He says, "I called you a year ago about an endometrial cancer patient who had failed everything, including pembrolizumab, and had so many lines of therapy, she was not eligible for a clinical trial. And you said that I should give her sacituzumab govitecan." I said, "Okay, that sounds like me." And then I was just waiting for him to say how bad it worked. He said, "She had a durable partial response." I said, "Phew, that's interesting." Now let me teach you about these TROP2 antibody drug conjugates, and I'm going to need your help. And again, you taught us about tisotumab vedotin ocular toxicity. Okay, the one of the toxicities here for these TROP2 antibody drug conjugates, all three of them, Dato-DXd, sacituzumab govitecan, trumatecan, is stomatitis. Okay. You also taught us that if you use vasoconstriction, you can limit the toxicity to the eyes and the nose. And you and I have used together cold caps, vasoconstriction, cryotherapy, you can reduce alopecia. So why don't we use cryotherapy in the mouth to reduce mucositis? So I had a patient. Brilliant, right? So I had a patient, still have a patient, who got sacituzumab trumatecan and had mouth sores. She found this mouthpiece, which you freeze in the freezer, and then you bite on it while you're getting the infusion. and right. And then she said, I thought that the medication would be out of the system in 4 days. So I used it 4 times a day. That's what the manufacturer said. And we also do dexamethasone mouthwashes. And she said, I got the same dose the second time with this cold mouthpiece, and I didn't have a single mouth sore. So that's, now you have your marching orders, is to learn about that. And these TROP2 antibody drug conjugates, which, have 2 of them approved, tisotumab deruxtecan, the same linker payload as trastuzumab deruxtecan, and govitecan, and maybe someday trumatecan. So cryotherapy works, and I'm excited to share that with you. I get it. I've only had one patient. I get it. It wasn't my idea. It was the family's idea. But generally, most things I learn from others. So I try to pass it along.
Simple solutions, right? Simple solutions.
Don't you think?
Can be. Right.
And literally, I love it when my patients are teaching me. I try to be teachable. She has a cooler, and so she has the 6 mouthpieces that she froze at home, and they walk in, with the mouthpieces, and they do it during the infusion. So we'll see how that works. And I'm going to meet with the company that makes them next week, and so I want to use them more.
Perfect.
All right. Well, that's a heavy lift from prevention to treatment across several lines of therapy and several classes of agents. I want to close, and I'll give you the last word, Kimberly. I want to close on this note. Number one, now I can tell you that we can sort of run from cervical cancer through prevention. But once you get it, you can't really hide. You have to fight. And so I thank all of you for being courageous providers, more importantly, the patients and those of us that do clinical trials. But I want to give you, Kimberly, the final word on what you've learned in treating cervical cancer patients and in the words of wisdom that you've been able to gain and paying it forward. Go ahead.
That's humbling, the scenario that you painted for us. And like you said, when we have cervical cancer, when our patients have cervical cancer, we cannot hide from it any longer, right? And I've learned that these women are fighters. Whether it takes a little bit longer to find that fight in them, or it takes some encouragement to find that fight in them, they all have it. And we are here, we're humbled and lucky enough that they chose us to fight with them. And I'm excited to do that with our patients. I'm excited to fight with them. And I'm excited for the new opportunities that they have, that you've described to us with the new medications coming down the pipe. And we will continue to fight with them.
So, and of course, it takes an entire team. And I appreciate you for being that part of that team as these patients receive the best care. So lastly, let me leave you with some SMART goals, which are smart, measurable, attainable, relevant, and timely, that are intended to be actions that you can take back to your clinical practice, maybe even starting tomorrow. So thank you.
I'm in Arizona, Dr. Monk. I'm going to use them today. It's early in the morning. I'm going to use these tools that you provided with us, and to the rest of us listening, the fantastic opportunity that you've given us to educate ourselves and our community. So thank you.
Well, I appreciate that. So thank you so much. We're in a good place. Let's encourage the use of HPV vaccination as a tool. Let's document delivery of guideline-based therapy in our electronic medical record. Let's recognize the challenges, fight them, and win, and sort of use these emerging therapy options and continue participation in clinical trials. So thank you, Kimberly, for joining me today. And thank you to our listeners for joining us today. And thank you for providing the very best care to your patients with cervical cancer. So long for now.